What if the very thing helping someone survive is also the thing destroying their life? And what if removing that coping strategy too quickly or confronting trauma too quickly can unintentionally increase the risk of relapse, emotional collapse, or treatment failure? This is one of the central challenges in the simultaneous treatment of PTSD and substance use disorders. And despite decades of research and clinical experience, many clinicians still struggle with one difficult question: how do we help people heal from trauma while also helping them stop using substances that may have become their primary method of emotional survival? These are not easy cases, and they rarely respond well to simplistic treatment approaches. Many individuals with PTSD and addiction live in a constant cycle of intrusive memories, hypervigilance, shame, emotional numbing, anxiety, avoidance, isolation, and attempts to regulate overwhelming emotional states. Substances often become more than recreation or habit. They become psychological anesthesia, an attempt to sleep, an attempt to feel calm, an attempt not to remember, an attempt to escape. And this is where treatment becomes extraordinarily complicated. Imagine a client who successfully stops drinking for several weeks in a structured addiction treatment program. On the surface, things appear to be improving, but underneath the sobriety are severe nightmares, intrusive memories, chronic anxiety, hypervigilance, and emotional pain related to unresolved trauma. The substances are gone, but the suffering that fueled the substance use remains untreated. Over time, emotional exhaustion increases, sleep deteriorates, anxiety intensifies. The individual begins feeling psychologically trapped, and eventually relapse occurs, not necessarily because the person doesn't care, but because the substances had functioned as an attempt to regulate overwhelming emotional distress. Now imagine the opposite scenario. A client enters treatment highly motivated to confront traumatic experiences. Trauma processing begins quickly, but insufficient attention is given to emotional stabilization, relapse vulnerability, coping capacity, environmental stressors, or the client's ability to tolerate intense affect outside the therapy office. The trauma work activates overwhelming emotional states. Sleep worsens, cravings intensify, avoidance increases, and the person begins using substances again to escape emotional flooding. The problem was not necessarily trauma work itself. The problem was timing, pacing, readiness, and insufficient stabilization. These are two very different clinical pathways, but both illustrate the same core principle. Effective treatment of co-occurring PTSD and addiction requires integration, flexibility, pacing, ongoing assessment, and careful clinical judgment. One of the greatest mistakes in treatment is oversimplification. Some approaches unintentionally communicate, get sober first, then we'll deal with trauma. Other approaches move too rapidly into trauma processing before sufficient emotional regulation skills, therapeutic trust, or recovery stability have been developed. The reality is that treatment often requires clinicians to continuously monitor readiness, emotional tolerance, relapse vulnerability, coping resources, motivation, avoidance, environmental stability, and the individual's broader sense of meaning, identity, and hope. Another major challenge is that many individuals gradually begin defining themselves entirely through the lens of trauma or addiction. Treatment then becomes more than symptom reduction. It becomes helping people rebuild identity, rebuild trust, rebuild purpose, rebuild relationships, and rebuild the capacity to live fully rather than merely survive. This is why integrated approaches can be so valuable. Models such as motivational interviewing, CBT, REBT, seeking safety, skills-based stabilization approaches, and carefully timed trauma-focused interventions can all play important roles when thoughtfully integrated. And increasingly, clinicians are recognizing that recovery is not simply about helping people stop using substances. It is also about helping them develop emotional resilience, psychological flexibility, meaning, connection, values, and a life worth protecting. In an upcoming in-depth Zoom lecture, I'll be exploring many of these issues in much greater detail, including common clinical mistakes in treating co-occurring PTSD and addiction, how to assess readiness for trauma work, emotional regulation and stabilization strategies, working with shame, guilt, and avoidance, balancing safety with growth, timing and pacing of trauma interventions, meaning-centered approaches to recovery, and practical strategies clinicians can immediately apply in real-world settings. So if you work with trauma, addiction, or co-occurring disorders, or simply want a deeper understanding of these complex clinical realities, please watch for the upcoming registration announcement and lecture details. Thank you for the important work you do. And remember, recovery is not simply helping people stop suffering. It is helping them rediscover the capacity to truly live again. This presentation is for educational and informational purposes only and does not constitute psychotherapy, medical advice, diagnosis, or crisis intervention. The clinical examples presented are fictionalized composites created for educational purposes and do not depict any specific individual. Viewers experiencing psychological distress, trauma-related symptoms, or substance use concerns are encouraged to seek assistance from a qualified healthcare or mental health professional.